So I can start? Yes. Thank you very much. First of all, thank you very much for giving me the opportunity to represent our data here. I will talk about advances of clinical exome panel testing in the field of cardiology, focusing on clonal hematopoiesis as an incidental finding. So my name is Elif Dagdan. I am a human geneticist. First of all, because I don't know your background, I will just briefly talk about a little bit about the background. 1 minute, the timer is not showing anything. So, next generation sequencing, it is a very powerful platform which has revolutionized the medicine, particularly precision medicine. In the field of oncology, we made a huge advantage thanks to next generation sequencing platform, but for the treatment of cancer patients, for example. Next generation sequencing is a modern DNA sequencing technology that allows rapid and particularly simultaneous sequencing of millions and billions DNA fragments, enabling the comprehensive analysis of our genome, transcriptome, and genetic variations. We are able to sequence like the 4 to 5 decades. Next generation sequencing refers that we can do the next generation sequencing the last 2 decades. The biggest advantage is that we can sequence simultaneously many people in same platform. So we have short and long read sequencing, but most of the steps are similar to the next generation sequencing. First of all, after we extract the DNA or RNA, we generate libraries, which means the areas which we are interested, we copy, generate so-called libraries, and sequence them in different platforms. And after the data is generated from the sequencer, we do the data analysis. So first of all, we human geneticists are focusing on the data analysis. After the data is ready from the sequencer, we have the variants which has been detected through the sequencing. We first of all look if the variant is true positive, is as an artifact. The second most important thing what we are doing is just looking after the variants we detected or mutation we detected. If it is a pathogenic or likely pathogenic variant, is it clinically relevant? If it is clinically relevant, our job is to see if it is therapy relevant. But most important thing what we are doing as a human geneticist is that we are not just looking after a patient, we are analyzing a family and explain the patient the mutations we are detecting, what it means for the whole family. This is the most important task we have. So after the interpretation, after the report, we can then more precisely treat the patient or tell the prognosis, whatever the question was. So first of all, just to give you background information, we can sequence whole genome, which is mainly done in the research. But in the diagnostic now, with the cheaper sequencing, we can do exome sequences, which is just 2% of our genome, where our genes are coded, called exome sequencing. And we can also do targeted gene panel sequencing, like depending what the phenotype is, we can focus on specific amount of genes and do the targeted gene panel and analyze some genes. So there are different possibilities. So I am the leader of the Center for Medical Genetics in Bochum, Germany. Bochum, Germany lies on the west part of the country. I don't know, west part of the country, North Rhine-Westphalia, which contains like 25% of German population lives in North Rhine-Westphalia. Our task is that we are integrating cutting-edge genomic technologies into the diagnostic research, and which is most importantly, our job is the patient care. So since I'm working with many different type of clinician, but particularly with the cardiologist, because my partner is a cardiologist, And we also do hemato-oncology, liquid biopsy, which is the analyzing cell-free DNA from the blood. It's a very, very interesting field in the medicine. Hematology, we do also genetical counseling, which means we are talking to the patient where we have a suspicion of inherited diseases, but mainly cancer patient, pharmacogenetics, ophthalmology, and also pathology. So since we had so many different type of clinician and I had so many different type of platforms, I decided to go for an exome analysis because it's at the moment, because of the lower cost, we were able to generate those big data. First of all, we bought a very good sequencer, AVITI, and we tested 2 different type of platforms. So first of all, I tested the Actionable panel from QIAGEN, which is a clinical exome panel where we analyzed 10,000 genes. And a second competitor had a whole exome panel with spike-ins, so also exome and non-coding areas which are clinically relevant is covered. I looked for 8 different patients, and we had also for cardiomyopathy a positive control with 24 positive mutations. I used many type of tertiary analysis platforms where I could generate, I could interpret my data. Just brief information about exome panels from the QIAGEN, the Actionable exome panel. It is very, it has a very common workflow, and it covers about 4,000 genes, whole gene, and 6,000 hotspots areas. So it was good enough for us. But the reason why I decided for this platform, not that other one, we could get the data after the sequencing in 15 minutes. I generate every week 160 gigabyte of data. So analyzing those data is a really big hard work. Since I was using a clinical exome, just focusing on 10,000 genes, the sequencing cost was cheaper, of course, because I was not covering a whole exome. The other advantage which the platform gave me was the library preparation was very robust and stable. There are sometimes methods in the lab just only one person can prepare, and we never know why it is. And this is why since this method was stable, I went for it. In Germany, we have a very big problem with our internet. So with the exome panel, we have to upload like 160 gigabyte data every week. It can take up to 3 days. Like local possibility with 15 minutes was one of the most important reasons why I have chosen it. And with that platform, I can also analyze 2 genes without uploading the information in any databases. And of course, since I had like 10 years experience with my colleagues, and I decided for this platform. So just to your information, what we human geneticists do, but at the genetical counseling, we first of all look for the family and see what the patient might have. What is our suspicion? We have done it previously because we had a limited opportunity to sequence genes. Now that we do exome, so we can see everything, so we don't need to know whole family history. So we can give the information within the platforms. Just to give you a very brief background information, we have a somatic mutation, which happens over a time of person's life, which starts in a single cell, like it can lead to cancer. This somatic mutation cannot be inherited. Then we have germline variation, germline variants, which are inherited from your parents. It contains in all our body, and it can be inherited to the next generation. That's very important to understand this part. So, in the field of cardiogenetics, cardiovascular disease, we have a lot of different type of disorders. In every field, you would have always overlapping genes or overlapping phenotypes of different disorders. So it's not like one disorder, one gene. You will also have different type of overlapping illnesses. And using panel analysis or using like limited amount of genes, you cannot cover everything. I mean, some person might have cardiomyopathy, but you might think it has a another disorder. So an exome panel gives us also the opportunity to analyze more broad, very rare gene mutations. Like, this is a very, very interesting and very important data I generated the last 2 years. So we established 2 years ago our Center for Medical Genetics. 2024, I started the first patient to analyze like August, September. In 2024, we had 148 cases. So 148 cases from the cardiology. If you look at the data from the 148 patients, our reported reports were 24%. Like 24% of the cases had a positive report with amplicon-based 86 gene panel. We were just focusing on the most common, well-known characterized genes, and 24% of the patients were positive. Then we decided and established at the end of the year the method. 2025, we started with the Exome panel, and we had 591 cases up to date. And as you can see, the picture is absolutely different. So you can see that out of 591 cases, 63% of the cases had a positive reports. Why? Because like with the amplicon base, we were focusing like at the cardiomyopathy, for example, at 24 genes. With the exome panel, we were able to focus on 157 genes, for example, which has been associated with cardiomyopathy. Of course, the broader you look for mutations, the broader you look for variants, the genes, then you will, of course, detect more mutations. So we could help way more patients to detect their inherited mutations. Of course, we have also in genetics incidental findings. What does it mean? Incidental finding is if you have a mutation, you find a mutation which doesn't have any thing to do with the patient's previous suspected disease, for example. Most common are what we are finding in our department is like inherited cancer genes. So as you can see, clinical exome testing is in the cardiology increases the diagnostic yield. So I have spoken of incidental findings. Case number one, which, the case in our lab 141, is a male patient, age of 84. He was 84 years old. He came because there was suspicion of clinical hypercholesterolemia. He had also coronal heart disease. And when I was analyzing his data, I have seen a mutation because I am doing hemato-oncology. I was familiar of TET2 genes. And I have seen that he has a nonsense mutation where I knew it is pathogenic. And I have also seen that's 25%, that means it is somatic. And immediately I called my good friend, he's a hematologist. We are working together, cardiologists, hematologists, oncologists. We are all working interdisciplinary in our hospital together. I immediately called him and I said, you know, patient 141, he has TET2 mutation. How comes? It's somatic and it's a true positive. And then he looked at his recorded information. He said, you know what? He has chip. I said, what is chip? I mean, my cat has a chip. But why does he have a chip? So I will tell you right now. Just but before I explain you how I came to find this mutation, because when we analyze, when we sequence 10,000 genes, roughly 8,000 to 9,000 variants we detect. Of course, we don't go through all 9,000 and look if there is any pathogenic. We have like criteria, we have artificial intelligence which help us to filter those variants. I don't know if you can see, we filter the variants. And we have roughly 300 to 400 variants which might be interesting to look at. But then the good information is that we can also focus on phenotype. We have HBO terms. We write down the symptoms of the patient, say he has that, he has this, he has that. This is the suspicion. And then it calculates the probability and says which genes can be. So, and in this case, this platform told me TET2 might explain his phenotype. So this is why I called my the colleague hematologist and us discussed with him what it could be. So since we had his record, the information in the cardiology, we could say that he has CHIP. What is CHIP? CHIP refers for clonal hematopoiesis of intermediate potential. So which is very important to understand is there are somatic mutations in the hematopoietic stem cell leading to a clonal expansion. There is no cytopenia or hematologic malignancy, which is like in a World Health Organization criteria. There are very common, few genes are mutated. It has to be detected in, which is called variant allele frequency of 2% in the white blood cells. What that means is that 4% of the white blood cells has to have those somatic mutations, so you can speak about a CHIP. So, of course, prevalence increases with the age. I was personally very surprised to know there are so many data showing, many studies showing like 10 to 20% of the population at age of over 70 has CHIP, which leads to a higher risk of hematological cancer, cardiovascular diseases, for example, and prognostic is like if you have CHIP, every year you have 1% more chance developing hematological neoplasies or malignancies. Those data is also mostly found as incidental in NGS data. First of all, as I said, it is accumulating with the age. We have, of course, also germline risk factors, which leads to CHIP. Sex differences, men are more likely to have CHIP. And of course, as you know, genotoxics, smoking, for example. And what does it do? If you get somatic mutation, depending the combination of mutation, you can have malignant outcomes, leukemia, lymphoma, for example. You can have cancer. Depending, cancer doesn't exist overnight. It is accumulation of different mutation that it leads to the cancer. Depending which mutation, how unlucky you are with this accumulation of the mutation, you can develop cancer. On the other hand, if you don't have non-malignant outcomes, then the CHIP can lead to increased risk, a very high increased risk of like cardiovascular disease, coronary artery disease, heart attack, stroke, ischemic heart failure, COPD, chronic kidney disease, rheumatoid arthritis, osteoporosis, and thrombosis. Those are also illnesses we absolutely also know, which is increasing also with the age, but we absolutely know people having CHIP mutations in their leukocyte, which leads to different, I will show you, different mechanism leads to increase of these illnesses. So as I said, there are many common genes which are mutated and accumulates with the age, and in different population we have different risk factors. So first of all, very important for you to understand functional effect of these key mutations. The most mutated one is DNMT T3A, which is a DNA methyltransferase. Loss of function leads to expanded self-renewal of hematopoietic stem cells. TET2, which is more common in the cardiology, because this, the function of this gene is the DNA demethylation. Loss of function leads to increase of the inflammatory processes, which leads then to cardiovascular disorders. And there are many genes where when we find a mutation which leads to different mechanism and leads to cancer. So second patient came, he was also a man, 65 years old, with aortic aneurysma. And we focused on 80 genes and looked if he has a genetical risk for developing aortic aneurysma, which is very common in the human genetics to test, because depending on the mutation, the patient can get a surgery or not, depending the size of the aneurysma. So again, here I also find a TET2 mutation. It was pathogenic, and I asked him to go to a hematologist to see if he has a precancerous state. So we cannot know that just finding the mutation doesn't mean the patient has a cancer, but they had to go to oncologists and hematologists to check for different information. Case 3, it's just it was actually healthy patient with 57. He had a lung cancer, and he wanted to know if he has if he has hereditary cancer predisposition, because he had 2 girls. And he had also coronary heart disease. So I found 2 different types of mutation, which were not variant of unknown significance. But interestingly, and he was also a brother of my colleague. And this is very interesting, because it was in a hotspot area, and that was a risk factor for leukemia. Since I was in the hemato-oncology department, I said we do a myeloid amplicon-based myeloid panel, sequence it very deep, because somatic variants, since they are in a very low allele frequency, you don't see at the germline analysis. So I sequenced the DNA one more time, very deeply, and I couldn't really find that he has, CHIP again. So now we are trying to find out if he has a cancer, or if his coronary heart diseases because of that chip. So that's all I can present about data, about our patient. So what was very important for me to tell you, having an exome panel enabled us to help so many different type of patients having inherited cancer disease. Of course, we have to have the acceptance from the patient to report this. We ask, before we do the analysis, we ask if they want to know any incidental finding. So it is in our German law, we have to have their agreement. If they want to know any incidental finding, and if we know there is a cure or there is a prevention for those disorders, of course, we report that. And every single person here will have 3 different types of mutation which will lead a disease. But most of the time, if you're lucky enough, they're autosomal recessive, but which is very important for your family member to know. With the advancements of this technology, it's sometimes like crazy to see in the future and to tell and to prevent, particularly the most important thing I really do is like not treating the patient because of the finding the mutation, preventing the illnesses of the family members. This is, I think, most important thing we human geneticists do before any mutation causes an illness. We can prevent many, many things. And I can understand some people don't want to know, but these mutations has been there before you are being even born. So sometimes it's also good to check up and see if you can prevent any illnesses, particularly if you have a family history of a specific disorder. So thank you very much for giving me the opportunity. If you have any question, I'm happy to answer.